to the globulate cells. But different refractive surgery has a different level of transection of nerves, such as in LASIK, the transection of all subbasal fibers through the flap side cutting extended to 300 to 310 degrees. Also, excimer laser ablation of the stoma damages the deep central corneal stomal nerves. In the silk or lenticule procedure, peripheral nerve fibers are resected only in 25 to 50 degrees. Incision is placed. Fibers that perforates the Bowman layer within the area of refractive lenticules are also resected. In PRK, because there is absence of flap creation, theoretically results are better in preservation of subbasal nerve plexuses and less severe nerve damage, and faster corneal reinnervation is observed. There are various studies already published in literature which says that dry eye symptoms, especially the Prowl study, which says that dry eye related symptoms are more after LASIK. Also, if we compare the lenticle extraction as well as LASIK, SMILE shows less negative impact on the ocular surface parameters. Although the reported prevalence of post-LASIK dry eye ranges from 36 to 75%, almost all patients experience some degree of dry eye in the immediate post-op period. Where do we stand at present? Conventional dry eye examination include tests such as tear film breakup time, Schirmer's tear film osmolarity, fluorescein or lissamine green staining, and meibomian gland scoring. Many of these tests, however, have poor specificity and likely to be affected by human errors. In addition, the objective results of these tests and the subjective symptoms may correlate poorly. Many of these tests are invasive and time-consuming also. So what we did is we found out a research question, can we have a novel, non-invasive, reproducible diagnostic test which can evaluate the ocular surface changes in the patients undergoing lenticule extraction and to correlate these subjective symptoms of the patient. What is thermography? The concept of thermography has already been in the literature. It measures the surface temperature of an objective non-invisibly using a thermographic camera operating within the infrared range. Various studies have shown that the thermography results correlate very well with the dry eye symptoms. This was a study of 30 eyes done at Shroff Eye Center. It's a prospective interventional study. What we did is we did first dry eye evaluations using Schirmer's, imaging with oculus keratograph and LipiView. Also, a validated dry eye questionnaire was used pre and post operatively, as well as variability in ocular surface temperature during interblink interval using an ocular surface imager was done. Thermographic metrics like compactness, convexity, and severity scores were studied. So this is a short video showing that this device is a slit lamp mounted device connected with a screen to it. And in this, what we did is we did in restricted as well as non-restricted mode, in which we asked the patient to do not blink for as much as time possible. So this is a color coding of the thermal images. Warmer color shows warm temperatures and cooler color shows cooler temperatures. And the parameters analyzed were compactness, which shows the closeness to the regularity of the shape, convexity, which shows the deviation of the completeness of the shape, and severity is the score derived from the above two, indicating the instability of the tear film. What we found out in the results that the Schirmer's pre-op as well as post-op is almost same in all the lenticule extraction patients. However, p-value was not significant, same for lipid layer thickness and NK beauty. When we look at the thermography parameters, in terms of severity, the p-value was statistically significant. Convexity also shows a significant result, and compactness was better in the patients after lenticule extraction. What this study adds is dry eye and ocular surface inflammation is relatively less in lenticule extraction, and thermography can play a pivotal role for diagnosis, which correlates better with the subjective symptoms. I would like to conclude by saying ocular surface imaging showed less severity, good compactness, and convexity following lenticule extraction procedure. Thermal imaging correlated better with the patient complaints than the tear film metrics. Lenticule extraction does not cause significant worsening of tear film metrics, and further analysis and a large sample size is required to further validate our findings. Thank you.
Thank you, Apurva.
Thank you, ma'am.
Any questions?
Did you go for other studies and did you compare your studies?
Yes, sir. We have done a study for the post-op LASIK patients as well, and we found out the results are better in the lenticule extraction, especially for the dry eye symptoms. And we are one of the studies undergoing for the dry eye patients as well, in which we see the parameters of thermography compared to the subjective symptoms are much better, are much comparable actually.
Thank you.
Thank you, sir.
What was your gap in the lenticule?
Sorry, sir? 110 microns.
So at 110, technically you're cutting the nerves, right?
Yes, sir.
Normally the nerves are 130 and below.
Yes,
That's
sir.
what I understand.
Yes, sir.
So then you are still saying that your dry eyes were lesser in lenticle at even 110.
Yes, sir. Thank you.
Now I invite Dr. Kumar Doctor to present his paper on toric marker for lenticule-based refractive surgery.
No, that's not the one. That's not the one. Toric.
Fourth presentation.
394. 394. Below that.
The toric marker for lenticle-based refractive.
Yeah. Thank you. Good morning, everybody, and thank you for adjusting the time as I have to run to another hall. I would like to thank Dr. Shivani who helped me to compile this. So what we have done here is we have invented a toric marker specially for lenticle surgery, which marks 0, 90, and 180, and there's a reason why we did this. As we know that all the marks which are there, it all depends on the system that we have. So I have a Z8, no financial interest. It's very important that we mark the cylindrical eyes, whichever have a cylindrical number. But I also decided that we have to mark all the eyes which also have a spherical error. And there's a reason why we did this. And the purpose of this whole idea was to make sure that we get perfect results as far as centration is concerned the next day. So we had 50 patients in a setting where we took myopic eyes of minus 0.75 CIL and above, and the highest limit being minus 5. So you can see on the right side that there is a toric marker. The difference here is that it is a modified Awad marker. I've removed the center ring so that we can look at the patient looking at the light, and so you got your visual axis. And I'm marking 0 and 90 on a Virion image-guided technology. So what's happening here is the marker length is long because on my technology, what we have, the marker, the camera situation is in such a way that the marks can be seen only in the center. So this is very, very important. Otherwise, if this is not visualized, because if we have toric IOL markings, they are on the periphery. But in this, we need them in the center, and that's the reason why I modified the marker. And that I got it right into the center. And all the surgeries were performed by me as far as the lenticle extraction is concerned. So all of them were done on the Z8, and we call it clear. It's corneal lenticle extraction for advanced refractive correction. And you can see on the right side, the marker is got a central circle so the patient can fixate the light of the microscope. So you got your visual axis. And the 3-prong marker is 90 and 180, which is done. And once the marking is done, we take the patient onto the femto system. And then after that, we make 1 drop of methylene blue because that highlights the mark which is there. And once that is done, we go ahead and do the lenticle extraction. So the whole system goes like this. So as far as you can see that the results are there, we can see the topography here, which is a very well-centered ablation. The advantage here is from day 1 to day 7, all of them become 6 by 6. Of course, depending on the experience that we had, now it's 2 years of experience. And post-operatively, we found excellent results as far as patient satisfaction was concerned. Thank you.
So, sir, this marker was kind of innovated by you.
Yes.
And you modified some other marker for it.
Yes.
You said. And spherical errors, can you just explain a little more, sir?
Yeah, so what happens here is in lenticle extraction, the pressure of the eye goes up. So the pupil becomes slightly eccentric. Now, when we are doing excimer laser and we are creating a flap, the pressure still goes up in most of the systems. We are centering the flap on the pupil. So technically, in a flap-based surgery, your flap may be slightly eccentric, but you don't need to worry because your excimer laser is treating the pupil. So even if your flap is slightly decentered, it doesn't really matter because the excimer is treating the pupil. Now, as far as lenticle-based procedures are concerned, the lenticule has to be on the visual axis. So when the pupil becomes slightly eccentric, if we move the lenticule to center it on the pupil, you'll have a decentered lenticule. So what we thought was, in this system on the Z8, it automatically aligns the mark. So when we have the marks, so it's all depending on the camera in your system. So the camera angulation in flap-based surgery on the Z8 is in such a way that you can see the whole applanated area. But in lenticle extraction on the Z8, the camera angle changes, so we don't see the entire applanated area, but you see the central 8 millimeter. You don't see 10 millimeter. And that's the reason why I made these markers longer, so that it comes towards the center, point 1. So once I mark on image-guided technology, I thought it is it can't go wrong, because that's a perfect technique of marking. Once we mark, I put 1 drop of methylene blue. Once that is done, it highlights the mark, and then increase the pressure on the Z8 to make the lenticule, and don't move the lenticule onto the center of the pupil. So you don't move the trajectory on the laser to center it on the pupil, but you just align it on this mark. So it may appear completely decentered. For example, on silk or on Elita, when you look at the image, it looks completely decentered. The reason why it looks decentered is the camera angulation. It's nothing else. It's very well centered. But here, then we decided to do this even for spherical errors, because the pupil will become little eccentric moment the IOP goes up. So even in spherical errors we are marking, and in cylinder errors also we are marking, and this made sure that we never have a decentered lenticule. That was the idea of doing this.
I think it's a very good study, and also it takes care of the cyclotorsion.
Yes.
So that's very important.
Yeah. So we've gone till 2.75 SIL till now, pure SIL, and I have a cap of 120. I'm not doing 110. I've done a few cases with 110, but with 120 also it's very comfortable. Thank you. Thank you, ma'am.
Thank you, sir. We have the next presenters, Dr. Salu Chandran, who will talk on correlation of psychometric personality traits with post-refractive surgery, quality of vision and life.
Good morning, everyone. I'm Dr. Shalu Chandran, and today I'll be presenting my study on correlation of psychometric personality traits with post-refractive surgery, quality of vision, and quality of life. There are no financial disclosures. As we all know, modern-day refractive surgical procedures provide excellent visual acuity and quality with high index of safety, efficacy, and predictability. But still, studies have shown that there are a certain number of patients who are dissatisfied irrespective of this excellent surgical procedure and 20/20 visual acuity. Also, studies have shown that personality traits have a fundamental role in the perceived quality of life, and it can influence the way people approach life and affect their level of subjective well-being. Therefore, post-operative patient satisfaction may also be influenced by individual personality traits. The aim of my study is to correlate personality traits of patients undergoing refractive surgery with post-operative patient satisfaction and visual quality. The study was done at Dr. Rajendra Prasad Center for Ophthalmic Sciences, and 46 patients who were planned for either LASIK or SMILE were recruited into the study after taking written informed consent. Along with the routine preoperative assessment, they were given self-administered questionnaires. Preoperatively, the patients were given Big 5 inventory questionnaire, which assessed their personality in 5 big dimensions such as extraversion, conscientiousness, neuroticism, agreeableness, and openness to experience. The quality of life was assessed using quality of life impact of refractive correction questionnaire and quality of life enjoyment and satisfaction questionnaire. Quality of vision questionnaire was used to assess the quality of vision, and these questionnaires were administered preoperatively as well as postoperatively at 1 month and 3 months. Coming on to result, out of the total 46 patients recruited into the study, 22 were male and 24 were female. 21 of them underwent LASIK and 25 underwent SMILE. Mean age of the study population was 25.13, and all our patients attained the visual acuity, uncorrected visual acuity of 6/6 at 3 month post-op. And each personality dimension was assessed separately in each patient, and thus the mean score for each personality trait as well as the dominant personality trait was established. It was found that agreeableness was the most common dominant personality trait in 35.9% patients, followed by conscientiousness, openness to experience, and extraversion. Neuroticism was the least common dominant personality trait. While assessing the correlation between personality traits and quality of life, using the quality of life enjoyment and satisfaction questionnaire score for overall level of satisfaction, it was found that conscientiousness has a positive correlation with the quality of life with a Pearson correlation coefficient of 0.344 at post-op 3 months, which was statistically significant with a p-value of 0.019. Extraversion also showed a similar positive correlation trend, but the results were statistically significant at post of 1 month only. Whereas exactly opposite negative correlation was noted between neuroticism and quality of life with a correlation coefficient of minus 0.355, which was again statistically significant with p-value of minus 0.015. But agreeableness and openness to experience does not show any statistically significant correlation. With while assessing correlation between personality trait and quality of life using the total QIRC score also, similar trend was seen. There was positive correlation with conscientiousness and extraversion, whereas negative correlation was noted with neuroticism. While assessing the correlation between personality trait and quality of vision using the quality of vision questionnaire, it was found that extraversion, conscientiousness, and agreeableness showed a negative correlation, which that is there was a statistically significant decreasing trend of few of the disturbing symptoms in the quality of vision questionnaire. Whereas for neuroticism, there was a positive correlation with the symptom of blurred vision, which is also statistically significant. Openness to experience does not show any correlation. Therefore, to conclude, patients' personality may have an impact on how they perceive their visual function when there is no obvious cause for dissatisfaction. Neurotic personalities tend to have greater likelihood of having unrealistic expectations and they have lesser postoperative satisfaction. Conscientiousness trait has a positive impact on self-perception of one's own health and they have higher satisfaction postoperatively. Extraversion also have positive emotional adjustment and they may also have higher satisfaction. Agreeableness and openness to experience does not show any correlation pattern in our study. Therefore, while planning for refractive surgery, it is worth performing a psychological examination of the patient and be cautious about selecting patients that score high on neurotic personality trait. Preoperative counseling can be given to such patients for a better postoperative outcome. Thank you.
Interesting study. Do you always at RP Center counsel patients, or do you have a counselor who judges the personality traits of these candidates, or you just take them?
Ma'am, in this study we took the personality trait. Otherwise, normally we doesn't look for personality.
So, in your experience or in RP Center's experience, what percentage of patients are really dissatisfied after refractive procedures?
Ma'am, different studies have shown that.
Your study.
Ma'am, in our study we haven't assessed exact percent patients who are dissatisfied. We just assess the score only. We doesn't give that criteria of dissatisfied or satisfied in that. Thank you.
So shall we call the next speaker? Is Dr. Zain Khatib here? It is his paper on impact of novel iSmart software on topography guided LASIK outcomes.
Thank you, AIOS, for this opportunity. So I'm going to be speaking on a software that I have developed and the results of this software. So we all know that topography guided LASIK for the Wavelight platform acquired FDA approval in 2016 to treat virgin eyes. The problem arises is when the anterior corneal cylinder is very different from the refractive cylinder. And then what exactly to do for topography guided LASIK is unknown. Some papers have published that you treat the manifest cylinder, while other papers have published that you treat the topography cylinder. So there was a software called the 4CDs software, which kind of took vector mathematics to calculate the difference between the two. So the aim of our study is to evaluate the outcomes of topo-guided LASIK using a new software that I have developed as compared to treating the manifest refraction alone. And my software is also based on vector mathematics and geometric optics, and it is similar to the 4CDs software. So this is how my software looks like. Once you enter all the data, the software automatically gives you what is the astigmatism coming from all the individual components of the eye. And then it will tell you what is the final refraction that you have to feed into the machine in order to proceed. So it was a single center prospective randomized trial of Contura topo-guided LASIK using two methods. We included 90 eyes of 45 patients, and the first eye underwent treatment using conventional manifest refraction, while the second eye was planned using the software, and the modified refraction given by the software was entered into the system. And the eyes for a particular group was assigned by simple randomization. It was a single surgeon femtoflap with Wavelight EX500, and Topolizer Vario was used to capture Contura images. Post-op analysis of everything was done at 3 months, and we excluded hyperopes, high refractive errors, unreliable readings, press biopsy, and any complication. We validated the study with the standardized graphs and charts given by JRS and JCRS. So these were the results. You can see both the groups, since they were from each eye was from a similar patient in terms of age, gender, pre-op sphere, cylinder, pre-op spherical equivalent, they were all similar. Ocular residual astigmatism, which is ORA, which is something that is important. It's the vector difference between the manifest and topography cylinder. That also was similar in both the groups. So there were no differentiating pre-op factors. What we saw is in the control group, the mean post-operative uncorrected visual acuity in decimals was significantly worse as compared to the study group, and this was statistically significant. When we look at the uncorrected distance visual acuity, 6 by 5 or better vision was achieved in more patients in the study group, that is 60% patients in the study group, while as 44% patients in the control group, although none of these were statistically significant. But if we look at the percentage of eyes gaining a line of visual acuity post-op, we can see that in the study group, 42% patients gained one or more lines of visual acuity, whereas in the control group, 22% eyes gained one or more lines, and this value was statistically significant. If we look at the post-op residual cylinder, we specifically studied cylinder because cylinder was an outcome that was very variable since we were changing it. So in this also we see that 100% eyes were within plus minus 0.5 diopter residual post-op cylinder compared to 89% eyes in the control group, and this value also was statistically significant. If we look at the post-op spherical equivalent, again the study group had better outcomes, but this was not significant. So, our study is based on a software that I developed. So we did a direct comparison with the 4CDs, which is also a third-party software. And you can see the outcomes are relatively similar in both these studies with in terms of percentage of eyes gaining good vision. So in our experience, Contura topography guided LASIK using the iSmart software yields superior outcomes as compared to treating manifest refraction alone. And the cylinder correction definitely seems superior with the software, and our outcomes are similar to the 4CD's analytical engine, which is already established. Thank you.
Please explain what you do differently in this case compared to the other software. It is the same thing you are doing, no?
Yes, sir. So it's basically a software which uses vector mathematics to analyze the corneal cylinder which is coming from the anterior cornea. It also considers the cornea from the astigmatism coming from posterior cornea. It calculates the total astigmatism, which is the refraction of the eye we feed in. Then by vector mathematics, it calculates how much is the astigmatism coming from the internal astigmatism, that is from the lenticular astigmatism. And then it takes an average of all these three and gives you the final.
It's already there, no?
Yeah, it has been made by me. I have coded the software for doing this.
Thank you. Sorry.
Are you going to plan a patent for this? Have you got it approved by some?
No, ma'am. Actually, the thing is that this is a very niche topic. Not, many people have much application for it. So it's not something that I'm patenting. It is just that if anyone, wants it or is interested, I can just give it to the person free of cost, as long as they are.
And just quickly, like, what was your journey? How long did it take you to do this?
It took me about a year.
Yeah.
It took me about a year. So it's actually I was very keen on the 4CD's analytical engine, which was supplied to a lot of doctors in India. But after a point, they stopped giving it to India. It is made by Dr. Mark Lobenoff in US.
Yeah.
So he was not allowed by Alcon to give the software after a point to Indian doctors. So because I wanted to do it, I started my journey of trying to make it myself.
And have you done a comparative on both the platforms as to?
So I don't have access to the 4CDs, but my colleagues who have it have compared, and you get very similar refractions that you put in using both the
maybe
softwares.
The next step would be to do a comparative now, because then you have a win-win situation when you have all the data,
Right.
and you calculate your sensitivity and specificity, and if your software is as good and is coming without a cost, then that's really, really a very remarkable innovation.
Right. So I did put the comparison of the two studies which were published, and in terms of outcomes, both seem quite similar.
Yeah. Congratulations.
Thank you.
So may I call upon Dr. Soumya now? She would be talking about safe way retrospective study to compare the results of PRK in high and low myopic patients. Dr. Soumya.
So no financial interest. So PRK is a surface photoablation technique in which the anterior corneal stroma is reshaped to correct the hemetropia by irradiating with argon fluoride excimer laser following epithelial debridement. More residual stromal bed remnant than LASIK reduces the risk of post-operative ectasia and the need for any enhancement procedures, which are the main benefits of PRK over LASIK. So in those cases that are unsuitable for LASIK, PRK offers to be an excellent alternative. The aim of the study is to evaluate the 24-month visual outcome of PRK in patients with low to moderate myopia as compared with high myopia. The primary outcome of the study was to document the postoperative UCVA, secondary outcomes being postoperative MRSE, efficacy, safety, predictability, stability, corneal haze, among other complications. So all those patients who presented to us between May 2020 to 2022 were recruited in the study who satisfied the inclusion and exclusion criteria and were divided into 3 subgroups, basically depending upon the refractive power as low, moderate and high myopia respectively, and they were made to undergo the pre-operative evaluation protocol. And the 6th generation MRS excimer laser version 500E squint iTech solution using OrCam software was used to do the procedure. 6.5 mm was taken as the average optical zone following excimer laser ablation. The stromal bed was soaked with 0.02 mmC of varied duration, 10 seconds being for each diopter, and then it was immediately irrigated with 30 ml of chilled BSS solution following BCL application. So post-operative regimen included uses of topical antibiotic and lubricants on an hourly basis, along with prednisolone eye drops for the first 3 days till BCL removal. Following the BCL removal, antibiotic drops were tapered down to 4 times and were completely stopped after 1 week. Lubricants were continued for 6 months. So in cases of low to moderate myopes, we have resubstituted prednisolone eye drops with loteprednol eye drops, which were tapered down from 4 times to on a monthly basis for 4 months. And in high myopes, we have continued the prednisolone drops itself on a monthly tapering basis for 4 months. So this modified steroid regimen helped us to decrease the post-operative haze in most of the patients. So in those cases that were steroid responders, prednisolone drops were resubstituted with loteprednol or cyclosporine drops respectively, as IOP monitoring was done at every visit for all the patients. So coming to results, Fisher extractors and Crusoe-Wallis test was applied as normality was not satisfied. The median ablation depth was 85 to 90 microns for high myopes, 40 to 60 for moderate, and 30 to 40 for low myopes respectively. So BCVA at the end of 12 months was almost the same across all the myopic refractive error groups, which indicating that it was not statistically significant. Only one patient in the high myopic group had BCVA of 6/12 in the right eye and 6/18 in the left eye due to persistent grade 2 corneal haze. This is because the patient was non-compliant to medications and follow-ups. The efficacy index was calculated as ratio of mean postoperative UDVA to mean preoperative CDVA, which was around 1 across all myopic refractive error groups, indicating that it was statistically significant. The postoperative MRSE across all the myopic refractive error groups was in a minimal range, indicating a good predictability value, as we can see in this linear regression line. And the safety index was calculated as ratio of mean post-op CDVA to mean preoperative CDVA, which was around 1 across all myopic refractive error groups, indicating that it was statistically significant. So as we can see, postoperative BCVA was unchanged across all myopic refractive error groups and was not statistically significant at the end of 12 months. Gain of 1 line and loss of 1 Snellen line was seen in few cases of high and low moderate myopes respectively. The safety and efficacy indices were excellent across all myopic refractive error groups, indicating a good predictability value and stability value. So a modified postoperative steroid regimen and use of PRK adjunct with MMC application, range being minimum application of at least 30 seconds for 1 diopter to 50 to 60 seconds for 6 diopters or more, helped us to reduce the immediate postoperative corneal haze in most of the patients. Few patients in the high myopic and moderate myopic group did have dry eye symptoms and night vision problems like glare and halos, but these were transient and improved over time. To conclude, our research shows that PRK is a safe, predictable, stable, and successful treatment with fewer complications for high myopia with results comparable to low and moderate myopes. Regression incidence and postoperative complications are minimal due to enhanced treatment profile, expanded optic zone, and transition from broadbeam to flying spot and use of wavefront optimized software. Limitations of the study being that record and follow-up of long-term outcomes such as efficacy, stability, and complications of PRK in high myopic refractive cases is also needed. So these are my references, and thank you.
-6, more than -6? What was the maximum you went?
Madam, we have subdivided into 3 groups. 6 diopters or more were classified as high myopes. 3 to
More means how much more?
till ma'am, MRSC we have taken as till -9 diopters, spherical and cylindrical together. So 6 to 9 most basically, and not more than -9. 3 to 6 was classified as moderate and less than 3 as low myopes for us.
What is the corneal thickness across the groups? especially in the
Average was
higher-
around 520, ma'am. Minimum being from 500 to 504, and maximum being till 565 to 570 respectively.
Is the refractive error correction the main aim, or did you have a grading system on the haze also? Because we didn't see any slide on the PRK
Grading
haze.
system on the haze actually was subjective only because like I didn't I do agree that I didn't keep this slide for the same, but we did grade it with Fante scale of grading, which was grade 0 for no haze, grade 0.5 for mild haze, and grade 1 when there is a significant haze but not obscuring the iris details and not interfering with the visual acuity, and then grade 2 for your moderate obscuration of iris details, grade 3 and
So, good you know that,
Yeah.
but there are enough
Yeah, we did,
publications on
yes.
PRK, high
Yes.
myopia, so and so forth. So this paper, if you want to make it more impressive the next time, because the results of PRK the publications are there in thousands and thousands of that. So probably if you're doing a comprehensive study on PRK results, then haze becomes a very important factor, because that's the only drawback which holds people to do PRK in high myopia.
Okay,
So how you dealing with PRK? What was the result? Because efficacy wise, we all know PRK is a great procedure, and all the higher generation machines are all flying spots and
Yes,
so and so forth. So 2 things you need to add in your paper. One is the haze criteria,
Yes,
and have
ma'am.
few clinical pictures if possible,
Yes, ma'am.
document that. And secondly is epithelial mapping. So
Okay,
that
ma'am.
also needs another slides and some comparative there, because that's a new thing. We are not doing PRK without epithelial mapping now. So if you
Okay.
get access to anterior segment OCT, so that will just make your paper much more comprehensive and better, so that you can present it in more international forums and other things.
Okay.
Good work.
Thank you so much.
May I invite Dr. Pranita to present her long-term outcomes of intracorneal ring segments with us.
Good morning, esteemed judges and my lovely friends. So, I'm Dr. Pranita Saha, and I'll be presenting on the long-term outcomes of intracorneal ring segment implantation with corneal cross-linking in keratoconus. So, as we all know, the management of keratoconus has 2 components. One is stopping the progression, for which CXL is the gold standard therapy, and the second is visual rehabilitation, for which glasses, contact lenses, Intacs, topo-guided PRK, and keratoplasty are used in a stepwise fashion based on the patient profile. So what is all known about Intacs is that it is US FDA approved, and it works by arc shortening effect and helps in improving the visual acuity and refraction in patients of keratoconus. But certain disadvantages like corneal melt, ring extrusion, and loss of CDVA has led to apprehensions for its use among refractive surgeons. Hence, in this study, we decided to assess the long-term visual and topographic outcomes of intracorneal ring segment implantation in cases of keratoconus to look at its results. The study was done at Center for Sight Eye Hospital, a tertiary eye care center, and included cases of keratoconus that underwent Intacs with CXL implantation and had an age of more than 18 years with a minimum follow-up of 5 years. The patients were operated between 2011 and 2016, were recruited for the purpose of study. The baseline and follow-up visual acuity, refraction, and topography were recorded. The primary outcome was change in BCVA, and the secondary outcome was change in refraction, topography, and the adverse events noted. Coming to my results, 24 eyes of 20 patients met our inclusion and exclusion criteria. The gender distribution was 50-50 between male and female. The mean age was 25.8 years, and the mean follow-up was 7.1 years. This is the follow-up breakup of the individual patients, and the range for follow-up was 5 to 11 years. 54% of the eyes were in stage 1 KC, while 38% was stage 2, stage 3, and only 8% was in stage 4 KC that underwent Intacs with CXL. All eyes except 1 underwent 2 ring segment implantation. Coming to the visual acuity results, so there was a statistically significant improvement in the best corrected visual acuity from 0.29 logmar to 0.12 logmar at final follow-up. 55% of the eyes showed more than one line improvement in the Snellen's visual acuity chart. 40% the BCVA remained same, while only one eye had a loss of BCVA that was less than one line. The manifest refractive spherical equivalent also showed a statistically significant decline from minus 3.35 to minus 2. More than one diopter decline was noted in 55% eyes, and only one eye showed worsening of myopia. Now looking at the change in spherical power, it also showed a statistically significant improvement from minus 1.39 to minus 0.48. The cylindrical power also showed a statistically significant decline from 3.8 diopters at baseline to 2 diopters at final follow-up. The Q value on the pentacam, which is an indicator of your shape of the cornea on pentacam, showed an improvement from minus 0.8 to minus 0.47. Kmax showed a decline from 58 to 55, and K-mean showed a decline from 49 to 46, both being statistically significant. The thinnest pachymetry did show a slight decline from 452 to 419 at 3 years, following which it stabilized. Coming to the adverse events, Intax was explanted in 3 eyes for corneal melt. The time from implant to explant was 8 years, 7 years, and 1 year respectively in case 1, 2, and 3. Vascularization of the channel was noted in 1 eye, and lipid deposition was noted in the channel for 2 eyes. This is a short video where we can see that even after a long term of implantation of Intax, explant is not very difficult. A thin slit incision was made right over the Intax ring, and with the help of a Sinskey hook, the hole was entangled, and it was gently moved out of the groove, pulled out of the groove in a circumferential pattern without damaging the overlying cornea. So the major complication rate was 12.5%, indicating that a lifelong follow-up is essential in these patients. Also, a logistic regression analysis for risk factor was done. However, none of these risk factor was found to be significant in indicating that whether the patient will have a major complication on long-term follow-up. This is a comparison of my study with the various other studies that have done a long-term outcome. However, what we found was different in our study was none of these study was giving a holistic idea of change in visual acuity, refraction, topography, and adverse event. We had focal information available in most of these studies. And the limitation of my study is it was retrospective in nature. While 54 eyes were operated during the study period, only 40 could be telephonically contacted and were doing well. Documented data was available for 24 eyes. Hence, the complication rate could have been overestimated. So to conclude, Intax with CXL results in significant improvement in visual acuity, refraction, and topography. However, there is a high complication rate present, and a lifelong follow-up is essential in these cases. These are my references. Thank you.
Very nice study, Pranita. My one query to you, now that CARES is also available, so what do you think is the thing for Intax versus CARES? Because here it's a foreign body, it's going to get extruded. You have a high 12.5% complication rate over a long period.
Yes.
And so do you think you would switch to CARES now?
Ma'am, CARES has been introduced a couple of years back. The long-term data is yet not available. I understand that this is a PMMA, and obviously in comparison to a corneal stroma, this may seem to be a foreign body, but CARES also is using a foreign body tissue, and the long-term results of how it is going to work is something we don't know. Yes, as at present, it is showing a very good improvement in the refraction, but the long-term results also need to be seen, whether that is going to be sustained over a long time or not.
Okay, the other thing is, you said the Kmax by 3 diopters is improved. So only with CXL also you see a lot of flattening.
Yes.
So do you think Intax, what is the actual role of Intax? How much percentage of your C3R patients or your keratoconus patients would you do Intax? Because it's such an expensive procedure.
Yes, ma'am.
The femtosecond laser channels is expensive.
Yes, ma'am.
Plus the Intax is also expensive. And then you tell the patient after the Intax that, okay, now your contact lens fitting is better. It's not like you spend $1.5 lakh and then you are not spectacle free or contact lens free. So what percentage would you do the Intax?
So ma'am, basically with the CXL, we all know that around 50 to 60% patient as such have a flattening of more than around 1 diopters, and the visual acuity also sometimes does improve. But it all depends upon what the patient wants. If with the contact lens, the patient's vision is say suboptimal, less than 618, and the patient really wants to go for a improvement in vision, this can be given as an option. The purpose of the study here was to basically assess what is the complication rate, because what is discussed about Intax is it has a very high complication rate. But if we look at 54 patients being operated, 3 had an explant, overall the complication was not so high. Here it appeared as 12% being high because we had only 24 patients for which the long-term data was actually available. So the purpose was not to see how much it is actually improving, but how much of damage it is doing to the eye.
Okay, thank you, Pranita.
Thank you, ma'am.
We'll call Dr. Ashmi Deshmukh for evolving trends in keratoconus.
Thank you, ma'am. At the outset, I'd like to thank AIOS for the opportunity to present this study. There are no financial disclosures. So keratoconus was initially described by Benedict Duddell in 1736, and even more than 250 years later, we still think that it's an enigmatic disease and it's not fully understood. Everybody is trying to make a difference in the management of keratoconus, considering that even cross-linking can only halt its progression. There are enough number of studies and there is data from various parts of the world, but there is a paucity of literature when it comes to Indian population. So there are several unanswered questions when it comes to our population per se. We wanted to look at the epidemiological data from Indian population, and also how has the trend of keratoconus changed in India, considering that there are now advances in diagnostics and management protocols and also in the disease understanding. So the aim of this study was to describe changing trends in keratoconus patients presenting to a multi-tier ophthalmology hospital network in India over 3 decades. This was a retrospective hospital-based study conducted from 1987 to 2020 data, and any patient who had a clinical diagnosis of keratoconus in at least one eye was included, and descriptive statistics was used to elucidate the demographic data in this. Coming to the results, we had 20,576 patients who presented over 30 years, and 63% of them were males and 37% were females. Looking at the trend of how the patients have presented, if you look at 1987 to 1991 block, we had only 173 patients, but now in the past 8 to 10 years, we have more than 14,000 patients of keratoconus who have been diagnosed. Looking at the age trend again, initially, the age at presentation used to be close to 30 years, but now the age at presentation has dropped down to almost 22.2 years. Then coming to the management protocols, we see that the overall trend of management or the interventions being done, which is represented by the blue line here, has increased. And looking at them individually, we see that, so the red arrows here are representative of when the contact lenses were respectively introduced in the contact lens management for keratoconus. And when we look here, the trend has been increasing. And now almost 11% patients are being managed with contact lenses for their visual acuity. Looking at collagen cross-linking trends, again, it was introduced in 2003 and we started doing it in around 2007. And now more than 6.6% patients are benefiting with collagen cross-linking. And then looking at the keratoplasty data, initially 100% patients used to undergo penetrating keratoplasty. Then somewhere around 2000, 2001 was when the lamellar keratoplasty was introduced and DALK started being done. But now almost 75% of the patients require collagen cross-linking, and keratoplasty has come down in the practice management. So coming to the discussion why this study was important, is that keratoconus was originally classified as a rare disease by the NIH, and it has a highly variable incidence rate which is reported. But it is also known that this is affected by the ethnicities, geographical area, genetics, and the diagnostic methods used by these different countries in their respective data sets. But we do know that nevertheless keratoconus is much more prevalent today than it was originally thought. Within the United States itself, the incidence has increased from 54.5 in 100,000 patients to 1 in 375 now in 2017 as reported. And this study from the UK has shown that keratoconus was 6 times more common in Asians than in white population, but we have very little literature from our population. There were 2 studies that I came across in India, but both were cross-sectional studies with relatively low sample size, and the criteria used for the diagnosis of keratoconus are also obsolete now. And when we look at the studies that have shown trends, there's only one study which has shown a 48-year trend from 1935 to 1982 and published in 1986. Since they had a very small sample size, there were no significant trends that they could enlighten us with. And since then, advances in diagnosis and management techniques in keratoconus have been seen, which would affect the trends that we see now. So what was already known is the prevalence of keratoconus has increased globally in the past few years. It is very common in Asians, but there's paucity of literature, and our understanding of keratoconus was mainly based on data extrapolated from other countries' studies. This study adds an increased understanding and better diagnostic modalities and newer treatment options have changed the demographic picture and management protocols when it comes to keratoconus. And this is the first study of its kind analyzing epidemiology and trends of keratoconus over a large data set over a long period of time. So to conclude, majority of the keratoconus cases that we saw were between 10 to 30 years age group with a male skewing. There is increasing number and earlier age at diagnosis and presentation. Contact lenses and collagen cross-linking are definitely game changers in the management, and there is a reduced number of keratoplasties that we see now. This study has given us a better understanding of the pattern of disease presentation in India and helps in the in improving the management protocols that we would follow. Thank you.
Very nice, beautiful demographic study, Rashmi. What were your diagnostic criteria, and did you include forme fruste or subclinical keratoconus also in this?
So diagnostic criteria, because because it has been studied over 30 years, this data, so whatever the diagnostic criteria were prevalent for that particular time frame and the diagnosis has been made as keratoconus by the clinician, those were the cases which were included. So for example, now we have Steinfluck topography and we might look at different trends, but when we had placebo-based topography and that time if it was fitting into the criteria, those patients were still included. So that is why we are looking at the trend. Because based on placebo, we had the age at presentation 30, and now based on our data, it's come down to 22. So that itself is like a trend shown on the advances in diagnostics. That is one thing. And one more question you asked, ma'am.
And forme fruste and subclinical keratoconus, did you include in this?
They were not included, ma'am. Diagnosis of keratoconus in at least one eye.
Is it eye-wise or patient-wise?
This is patient-wise because there were 20,000 patients. So the patient number itself is more. But the 14,000 patients of the last 10 years, we've studied eye-wise, but we've published it. So.
Have you done a breakup state-wise or region-wise in India? Because we know it is an established fact that the keratoconus incidence is more, the prevalence is more.
Yes.
But is there a demographic distribution that you figured out whether it's more in North India, South, East, West?
We have not been able to do that because this study was across the network of LVP. So the network is from Orissa, small part of Karnataka, mostly in Andhra Pradesh and Telangana. So we could include only patients draining in those areas.
That's from one region. And the other thing is that would you want to break it up into as it's actually more incidence, or is the pickup better?
So actually incidence this is a prevalence based study. Incidence we might have to look at more details, which would be difficult with the 20,000 data set. Also considering that at that time the kind of data that was being entered, because this is a retrospective analysis. So there is a lot of data which we might not get. For example, even when we looked at, in the interest of time, I have not included those results, but when we look at the family history pattern and those things, we had like 1.4% patients who had family history or 5.7% patients who actually had eye rubbing. But in 1980s and towards the late 1980s, when we look at the records, they would not even document it because that knowledge was not there at the time.
But what
now
was
we
the aim of this paper? I mean,
to
we
look,
know.
to look
I mean,
at the
it's an
demographic.
established fact that the prevalence of keratoconus is more.
It is an established fact from Middle Eastern and American studies, and maybe one study from Korea. That is the only Asian study. We don't have any study from our population. So if we want to make a difference in the management of our patients, we need to know the presentation of our patients itself.
So can we look at a retrospective analysis of a multicentric approach, or maybe look at it deeper into the regional distribution within India?
If it is possible, I mean, if the geographic areas and everything have been documented properly, because in a large data set, when we look at retrospectively, it depends on how it has been documented a lot.
So more work needs to be done.
Yes, it's a lot. Even this was like a lot of work, but when we go for geographic distribution, we might need more.
Thank you, Rashmi. The next speaker is keratometric and pachymetric changes post microLASIK, femtolasic and SMILE in Indian population. Dr. Himani Chatterjee.
A very good morning, everyone. So I'm here to present a study on the corneal curvature and pachymetry changes in patients undergoing microLASIK versus femtolasic versus SMILE in an Indian population. So why did we do this study was because this is an unpublished data in Indian population. There is only a single study done in the Chinese population which compares the SMILE and the femtoLASIK, corneal curvature and pachymetry. But as we know, there are ethnic variations in the Chinese and Indian eyes with respect to corneal keratometric power, pachymetry, and the anterior chamber depth. And also, there is no such data which compares all three procedures. So the objectives were to compare the corneal curvature and pachymetry changes post micro-LASIK, femto-LASIK, and SMILE in myopia and myopic astigmatism, and to see the stability of these parameters in the post-operative period. So we designed a retrospective observational study and included those who had undergone these procedures for myopia and myopic astigmatism and had a post-procedure visual acuity of 6/9 or better, and excluded those who had lost to follow-up. So patients fulfilling this criteria, out of them, 50 eyes had undergone micro-LASIK, 65 eyes had undergone femto-LASIK, and 67 eyes had undergone SMILE. So we reviewed their old records and we evaluated the best corrected visual acuity, spherical equivalent, corneal curvature, pachymetry, and Schirmer's test and TBUT on the baseline preoperative days, post-operative day 1 month, and 3 months. So this is an example of how we evaluated the old records of the patient in a micro-LASIK patient up to 3 months. So the baseline parameters were all non-significant except for the spherical equivalent, which was significant. The BCVA was non-significant. The change in BCVA was non-significant in all the cases, and SMILE, which is shown with the gray graph, shows a stable refractive outcome. In terms of average K, there was significant reduction in average K in all the procedures, but SMILE showed a slight increase in average K at 3 months, which was statistically not significant. The change in keratometry with respect to spherical equivalent was statistically significant in all the procedures, but SMILE shows a comparatively stable delta K by spherical equivalent. Pachymetry reduction was seen in all the cases significantly, but femto-LASIK, which is shown by the orange graph, shows a slight re-thickening at 3 months. The Schirmer's test was significantly reduced in all the cases, but micro-LASIK shows the highest reduction in Schirmer's as compared to SMILE, which shows the least reduction. So male predominance was seen in microkeratome LASIK in our study, and female predominance was seen in femto-LASIK and SMILE. And similar findings are seen in femto and SMILE group in the Chinese population too. SMILE shows a greater reduction in average K from the baseline in contrast to Chinese population. But this may be due to the significant difference in the spherical equivalent in our study. SMILE shows a lesser delta K by spherical equivalent, which is suggestive of a stable corneal curvature post-operatively. Similar reports seen by the Chinese population. There was an increase in average K at 3 months post-operatively in SMILE in our study, in contrast to the Chinese population, but this was not seen. But the difference between 1 and 3 months is not statistically significant. Pachymetry reduction was highest in SMILE, which is in accordance to the study done by the Chinese population, but corneal remodeling was stable in SMILE after 1 month. The Schirmer's test was least in micro-LASIK group, and similar reports are seen by Ganesh et al. So to conclude, the corneal curvature and pachymetry are not stable in the early post-operative period, and SMILE is more stable as compared to micro-LASIK and femto-LASIK in terms of stability of corneal curvature, pachymetry, and BCVA in our study of 3 months. And micro-LASIK has higher chance of developing dry eye disease. So this study provides valuable insights into the effects of different refractive procedures on corneal structure and stability in an Indian population. And future studies with larger sample sizes and longer follow-up periods could further elucidate these findings. So the limitations were this was not a prospective and randomized controlled study, and this was a single center study with a small sample size, and only 3-month follow-up data was there with us. Thank you. Yes, ma'am. For the micro-LASIK group, for 3 months, it continues to be at almost 12 millimeters. And in SMILE, it continues to be at around 16 millimeters, 15 to 16.
This is by Schirmer's.
By Schirmer's.
That's become a very redundant way of looking at the dry eye.
Yes, ma'am. We should also consider other parameters as TBUT and...
What about epithelial thickness? Did you study?
Yes, ma'am. Yes, sir. Actually, we saw a slight increase in the epithelial thickness in the femto-LASIK group. But as studies show, there is slight epithelial rethickening in of 10, 10 to 15 microns in after femtoLASIK. There is literature which shows this.
I think
So-
now the trend is to go for epithelial thickness in all cases.
Yes, sir. Yes, sir.
See, my plea, because you guys are younger, and my plea is when you're making a free paper, try to be more comprehensive, because these are very simple facts which are already there, so try and get something extra. And 3 months, of course, we understand is not a long term.
Yes,
so
ma'am.
obviously you've also put it as a limitation. But if we are, because it becomes, every study is also becoming machine skewed basis. All said and done, what we read, even in the best of journal and publications, is not a very, not all of them are very
Proper, yeah.
honest
True.
and proper. So we would love to have like a comprehensive data which is actually genuine. So if we are talking about dry eye, you may not pick up anything else, but just dry eye between 3 machines, because not many centers have all 3 machines,
Yes.
and just study that in detail and have a little longer follow-up. So that makes it more enriching, and actually then there is a take-home message and there's more authenticity.
Yes, ma'am.
to
Actually,
what
we
you've
are
done.
doing a prospective study right now, and we have a data of 6 months. So we are actually going for the statistical analysis. So not only dry eye, we have seen a lot other parameters which are going to change, which is not in accordance with the studies already done.
Yeah,
So we are very soon going to publish it, ma'am.
perfect. Sounds good.
Thank you, ma'am.
The final paper is Dr. Vikas Veerwal. He is here? No, he's not. Thank you, everybody. I think we have finished on time. Excellent papers. Congratulations to